at the beginning of this pandemic, general practice seemed to be completely absent from the discussion. It was almost invisible. It wasn't included in the policy, but that was really at odds with what I knew from my colleagues in East London, who were seeing plenty of cases that they thought were COVID. And the second thing that I thought was really important is that in our area of East London, which was at the sort of peak of the London pandemic, we have 55% of the population from ethnic minority populations. And so we were really well positioned to see if we could begin to sort of get to the bottom of this question about whether it was multiple health conditions or other sort of factors that we were recording in the GP record, which explained the high levels of risk for Black and ethnic minority populations. So those are the two main reasons that we set out to do this paper.
Tell me what you did.
And so what we did basically was devise a scheme for extracting data from the 4 CCGs in East London, which we, as the clinical effectiveness, we regularly work with them. And so their data streams into Queen Mary onto our server, and we have agreements with all these practices to use their data for research. We included obesity, ethnicity, and obviously we wanted to include multimorbidity. Now, there are any number of ways of measuring multimorbidity. Actually, it appears at the moment that the more simple ways are just as good as the more complicated ways. And we knew that the QOF conditions were well recorded in general practice, so we stuck to them. Then there was the question of smoking. Now, you may remember that smoking was a bit sort of contentious. And there were papers which were suggesting that the more you smoke, the less you got COVID. That we actually didn't collect the smoking data very well. So we eventually decided not to use the smoking in our multivariate model. But the other thing that we really wanted to do was to actually demonstrate the consultations. And so I'm really pleased with some of the graphs we've got in our results, which compare the consultations with upper respiratory infections with those for suspected COVID, showing how GPs were really able to clinically distinguish between the two. The other data I really like is we've got a graph showing the test positive cases in East London and compared with the suspected cases seen in general practice. And we were seeing 3 to 4 times as many as the test positive cases, but they absolutely mirrored the time pattern. I think the first key finding was that throughout the London pandemic, GPs were extremely busy seeing and managing COVID cases, even though they were invisible in the national discourse. The second key finding is that we were able to use patient-level data from the GP record to ask whether the high rates of COVID seen in Black and ethnic minority individuals are because of health-related phenomena or due to something else. And what we very clearly were able to show from these suspected cases was that although long-term conditions are risk factors, they don't influence the ethnicity rates. South Asians are nearly twice as commonly affected as whites, and Black people in our sample had a 1.5 rate of suspected COVID. These are not really affected by long-term conditions, even though those groups have more long-term conditions than white people. General practice is going to be incredibly useful as the pandemic rolls out into the future. It can be useful as a warning for future outbreaks. But there's also this whole question of post-COVID. What happens to all those people who've had COVID and need continuing care? And that's exactly why all those test results need to be sent back to general practice. It was a national disgrace that we weren't getting any of the test and treat results sent to us.